Welcome to the deep dive. We're ripping open a stack of your revision notes today, diving deep into a specific kidney condition you flagged for us.
That's right. We've got this detailed set of notes here, all focused on minimal change disease. It's, a topic that comes up quite a bit.
And our mission, to slice through these notes, pull out the absolute core knowledge, and present it to you in a way that's crystal clear, high impact, and hopefully easy to retain.
Yeah, think of this as your focused walkthrough. Everything essential about MCD, straight from this material you've given us.
We'll unpack everything these notes cover: what MCD is, why it happens, how it looks in a patient, the mechanism.
Diagnosis, treatment, prognosis, complications, the whole lot. We're sticking strictly to the information right here.
Okay, so let's settle in and get into it. The name itself is interesting. Minimal change disease. What exactly is minimal about it?
Well, it's quite specific. The name actually comes from how the kidney's filtering units, the glomeruli, appear under a standard light microscope. When you look at a biopsy that way, the glomeruli look, well, almost completely normal. Very minimal change is visible at that level.
Right, so it looks okay under one type of microscope, but clearly the patient isn't okay. That's interesting right from the start.
Exactly. It's a kidney disorder that really messes with the function of those glomeruli. And the notes highlight something crucial. It's the most common cause of nephrotic syndrome, specifically in children.
Ah, okay.
Though important to remember, these notes do say it can definitely affect adults too.
Yeah. Minimal look, big impact, mostly kids. So if the standard view is normal, what do these notes suggest causes it? What's going on?
Well, the notes are pretty clear that the exact cause isn't known in most cases. They call these idiopathic.
Right.
But the main theory presented here is that it involves some kind of abnormal response from the immune system.
The body attacking itself, sort of?
That's the general idea. Substances released by immune cells, maybe certain cytokines, are thought to damage the glomeruli somehow. The notes list potential triggers too.
Like what?
Things like infections, maybe a recent immunization, or even an allergic reaction could potentially kickstart this abnormal immune response.
So often a mystery, but possibly the immune system going a bit haywire after some trigger.
Pretty much. And while most cases are idiopathic, the notes do mention that maybe 10–20% have identifiable causes or, strong associations.
Are there specific things listed for those cases?
Yeah, they mention certain drugs, NSAIDs, rifampicin, also some associated medical conditions like Hodgkin's lymphoma and thymoma, even infectious mononucleosis.
Huh, okay. So sometimes there's a clearer link.
Definitely. It's not always a complete unknown.
Moving on then, who's most likely to get this? Are there specific risk factors outlined in these notes?
Well, the biggest risk factor highlighted is age. Minimal change disease primarily affects children, especially between 1 and 10 years old. That's the peak time, apparently.
Although it can happen anytime.
Yes, it can occur at any age, but that childhood bracket is key. The notes also say it's slightly more common in boys.
Okay. Any other risks?
Beyond that, the notes state specific risk factors aren't really well defined, but it does mention associations with things like allergies, infections, other autoimmune diseases, suggesting these might slightly increase the risk, maybe.
Right. Associations rather than definite causes.
Yeah.
Okay. Now, for the really crucial bit connecting the minimal appearance to the big problems, the pathophysiology, how does this minimal change actually cause nephrotic syndrome? What's the mechanism described here?
Okay, so this is where the electron microscope becomes vital. It shows what the light microscope misses. The notes explain the basic issue is a disruption of the glomerular filtration barrier.
The filter itself.
Exactly. Specifically, the glomerular basement membrane and those little cells sitting on it called podocytes.
So the filter gets damaged, even if it looks okay from, like, a distance.
Precisely. And this disruption causes a really key functional change. The barrier becomes more permeable. It gets leaky.
Leaky to what? What gets through?
Well, things that should stay in the blood start leaking into the urine. And the notes connect this increased permeability directly to the main features of nephrotic syndrome.
Your chart.
You get massive amounts of protein in the urine. That's proteinuria. Because you're losing protein, the protein levels in the blood, especially albumin, drop hypoalbuminemia.
Right.
That low albumin messes up fluid balance, causing major swelling or edema. And often high cholesterol turns up too.
So Damage leads to leakiness.
Yeah.
Leakiness means protein loss. Protein loss causes the swelling and other stuff. Is that the chain?
That's the core sequence, yeah. And the notes actually give a bit more detail on why albumin in particular leaks out so much.
Oh, yeah.
It seems to involve T cells and cytokines causing damage that specifically reduces the negative electrostatic charge of the glomerular basement membrane.
An electrical charge, like a force field.
Sort of, yeah. Albumin is negatively charged. Normally, the negative charge on the filter membrane repels the negative albumin, keeping it in the blood.
Ah, makes sense.
When this immune damage reduces that negative charge, the repulsion is lost, and albumin just slips through much more easily. The notes specifically point this out. Reduced charge increases permeability to serum albumin.
Wow, okay, that's a really high yield point then. It's not just a physical gap, it's this electrical barrier failing that lets the albumin escape. Immune system affects charge loss lets albumin leak causes the symptoms. That connects it all up.
Absolutely. It bridges that gap between what you see on electron microscopy, the fused podocyte foot processes, which change structure and affect charge, and what the patient experiences.
Speaking of the patient experience, these notes also list other conditions that can cause nephrotic syndrome. So what else could it be? What's on the differential diagnosis list here?
Right. The notes list the other main players that cause nephrotic syndrome, things like focal segmental glomerulosclerosis, FSGS,
Wow, yeah.
membranous nephropathy, and also systemic diseases that affect the kidneys, like lupus nephritis or kidney problems from diabetes.
All damaging the filter in their own way.
Exactly. And the notes stress that telling minimal change disease apart from these often needs a kidney biopsy. Seeing that minimal change on light microscopy is key, assuming everything else fits.
Right, the biopsy confirms or rules out. What about how common it is? Any epidemiology in the notes?
Yeah, they put it in the context of nephrotic syndrome overall. Globally, they say about 75% of nephrotic syndrome cases are in children, 25% in adults.
And for the UK specifically?
The notes highlight that in the UK, minimal change disease is the #1 cause of nephrotic syndrome in children. Accounts for something like 80% of those childhood cases.
80%? Wow.
Yeah, it does happen in adults in the UK too, but just much less often than in kids.
So predominantly a childhood thing, especially here. Okay, let's talk clinical presentation. What would you actually see in a patient, especially a child, with MCD based on these notes?
The most obvious thing usually is the edema. That's significant swelling, often really noticeable around the eyes, periorbital edema, and also in the ankles and legs.
And that's directly from the protein loss, the fluid shifting out.
Directly, yes. The low albumin pulls water out of the blood vessels. The notes also mention foamy urine.
Why foamy?
Just because of all the extra protein in it.
Ah.
You might also see fatigue, maybe the child's not eating much, decreased appetite, and some weight gain, but that's mostly the fluid retention.
Okay. Are there any signs that are typically absent in MCD which might point elsewhere?
Yeah, a key point the notes make is that high blood pressure, hypertension, is rare in minimal change disease. That can be important in telling it apart from other kidney issues.
Good point.
The notes also stress again that the proteinuria is highly selective.
Highly selective. What does that mean exactly?
It means it's mainly the intermediate-sized proteins leaking out, like albumin and another one called transferrin. Bigger proteins mostly stay put,
Okay.
which is different from some other glomerular diseases where you get non-selective proteinuria, meaning a whole range of protein sizes escape. That's another subtle clue these notes flag.
Interesting detail. And we mentioned the biopsy findings, but they're reinforced here under presentation too.
Absolutely. It's the diagnostic cornerstone. Light microscopy, normal glomeruli, the minimal change. But then electron microscopy shows the real problem. Those podocytes have fused, effaced foot processes. It's that hidden damage causing the functional issue.
It really is a disease of hidden changes. So how do you investigate, according to these notes, what tests get listed?
Well, the definitive test is the kidney biopsy. Like we said, confirms the minimal change on light microscopy, lets you check with electron microscopy, and crucially rules out those other causes like FSGS or membranous nephropathy.
So it's for ruling in and ruling out.
Exactly, essential for getting the right diagnosis. Beyond the biopsy, the notes list standard blood and urine tests.
What are they checking?
Measuring protein levels in blood and urine, checking kidney function, things like creatinine, urea, and lipid profiles, because cholesterol is often high, remember?
Right, connecting back to the pathophysiology.
Yeah.
And any other tests?
The notes mention additional tests might be done, especially maybe in adults or complex cases, to help rule out those associated conditions or other systemic causes we talked about earlier.
Okay, makes sense. So we know what it is, the likely why, how it works microscopically, how it looks clinically, and how it's diagnosed. Now, based on these UK-focused notes, how is it managed? What's the treatment strategy?
The notes are very clear here. First-line treatment is corticosteroids. They specifically mention prednisolone.
Steroids. Right. How do they help?
Well, the idea is they reduce that abnormal immune activity and inflammation that's thought to be damaging the glomeruli. The aim is to restore normal function, stop the protein leak.
And do they work well?
Yeah, the notes highlight good news here. The response rate is high. A big majority, around 80% of children with MCD, respond well to steroids and go into remission.
80% is pretty good for a first try. But what if they don't respond well or keep coming back?
Good question. The notes say if the response isn't adequate or if the patient becomes steroid dependent, meaning they relapse as soon as steroids are reduced.
Okay.
Or even steroid resistant, meaning steroids just don't work to get them into remission, then other immunosuppressive drugs might be needed.
Any specific ones mentioned?
For steroid-resistant cases, specifically, the notes mention cyclophosphamide therapy as a potential next step.
Okay, so a clear plan B and C if needed. What about the long run, the prognosis? What's the typical outcome according to these notes?
Generally speaking, the prognosis, especially in children, is described as favorable. Most kids respond well, and remission usually happens within weeks or maybe a few months.
That sounds quite positive. Is remission usually permanent, though?
Well, the notes indicate that relapses are actually common. That's a key feature of managing MCD.
Okay.
The prognosis in adults is apparently more varied than in children, and the notes mention a higher risk of developing chronic kidney disease later on for adults.
Right, so the relapses, that leads straight into complications. What are the main things to watch out for based on these notes?
The primary complication listed is exactly that, the potential for relapses. And the notes describe different patterns here.
Patterns.
Yeah, some children might just have one single episode ever, others have infrequent relapses, but then some have frequent relapses. These can be steroid dependent, needing ongoing steroids to stay well, or steroid resistant, which are tougher to treat.
So the relapses themselves are a major issue, driving treatment. And the treatment, are there complications from using steroids repeatedly?
Absolutely. The notes explicitly list steroid side effects as a significant complication. Long-term issues like osteoporosis, being more prone to infections, various metabolic problems like weight gain, blood sugar effects, stuff like that.
So managing the treatment side effects becomes a big part of managing the disease, especially with frequent relapses?
Definitely. It adds a whole other layer.
Is there any risk of the kidneys getting permanently damaged?
The notes do mention that progression to end-stage renal disease is possible, but it's described as rare in minimal change disease.
Okay, that's reassuring. And going back to those relapse patterns, do the notes give any rough figures? Like how common are the frequent relapsers?
Yes, they give a rough breakdown for kids. About a third might only have one episode. Another third have infrequent relapses, and about a third have frequent relapses, although these often stop before adulthood, apparently.
Okay, that gives a clearer picture of what to expect. Wow, that was a really thorough deep dive into minimal change disease, getting the essentials straight from your notes.
Yeah.
It's still fascinating how a disease named for looking minimal needs that more powerful microscope to see the real damage.
Yeah, and understanding that specific mechanism, the immune attack on the podocytes, that loss of the negative charge leading to the selective albumin leak, it really does tie the cause, the pathology, and the symptoms together nicely in this context. It's a great example of how tiny changes cause big problems.
For you, working through these notes, keeping that whole sequence clear seems absolutely vital. The likely immune trigger, podocyte damage and charge loss, selective protein leak, nephrotic symptoms like edema, usually a good steroid response, but watch out for relapses and steroid side effects. That feels like the core story from this material.
It really does. It shows there's quite a bit of complexity hidden under that minimal name.
So here's a final thought for you to take away and maybe mull over. Given how common relapses are, especially in kids, and thinking about the side effects of the steroids needed to manage them, what might the total long-term burden really look like for a child with frequent relapses? Not just from the kidney issue itself, but from managing those treatment effects over potentially years.
Yeah, definitely something to consider beyond just the initial diagnosis and response. A lot to think about, even with a seemingly minimal condition.
We really hope this deep dive has helped make those notes on minimal change disease much clearer and more high yield for you. Keep sending us the topics you want us to explore.